voices be with you again. So I know people are still gathering, so I will give it a few minutes, but I want to give you all an opportunity to air your grievances about the exam if need be. But I just want to say that you all did so well. And even if you don't feel that way, and no one's going to fail this class. And it's not because I'm going to pass you without the effort. It's because you're going to put in the work. And ortho is, it's not a lazy subject. That's not to say that any of you are, but it requires a lot of dynamic participation. So that's another reason why I'm giving everyone the opportunity to do these little clinical assignments as well, because it's tricky when the entire weight of your grade rests on the shoulders of a midterm and a final. So even if you haven't necessarily kept up with the assignments or your activity logs, I encourage you to do that, because those are extra points that are very easy to get, and they'll count for a lot. So yeah, does anyone have any comments about that or questions? Or it followed the study guide, so we'll continue to do that. And I think the home stretch here, I think, might be possibly easier to digest. One, because we only have a few more body parts to review. We're going to do the hip and glutes, and sort of upper thigh, and then the knee and the ankle and foot. So we only really have 3 major sections left to go. So to answer a question, the activity log, the grade for the activity log, or I shouldn't say grade, it's not graded, they're points. And if you even if you do nothing, I mean, the idea is not to I'm not judging or grading your level of activity. It's to kind of, one, give you an opportunity to use your own body to tap into body mechanics and your own, I mean, that's so hugely helpful. And movement and getting a treatment, an acupuncture treatment on a particular body part, teaches you so much about that particular part of your body. So one, it's an excuse and the homework to get up and move and, hopefully do something you enjoy. Two, to tackle the tremendous challenge that a lot of our patients have, and that I always had as a student and as a, practitioner now, carving out the time to take care of yourself and move and, get out there and get some exercise and not make sure that you don't get too stagnant. And also in the heat, and I know everybody's schedule is different. And when you're really busy, it feels impossible sometimes to make time for self-care. So it's an excuse to do that and a challenge to figure out how to do that when you're really busy, because like I said at the beginning, your patients are going to give you every excuse in the book why they can't do this or can't do that. And it's possible to be healthy and busy at the same time. So if you can't help yourself with that challenge, it's going to be extra hard to help your patients. And the things that you learn in an effort to sort of balance your own well-being are going to be really helpful to pass along to your patients too. So it's not a grade, but I will give you points for regardless. Yes, priorities, exactly. Regardless of whatever you do or don't do, it's nice to see, I mean, and it's honest and again, no grade. Even if every day you said didn't have time to move, study. I mean, that's fine, but take a look at that. And when we see it on paper and we're held accountable, we tend to think twice about that. And the same goes for diet logs. I mean, I have people write down what they eat, and sometimes they're very shameful and apprehensive about doing that. And I think I also shared with you early on, sometimes I'll just tell somebody, okay, well, between now and the next time I see you, write down all the vegetables you eat, right? And then if you see on paper that days go by and you haven't had a single vegetable, or you're held accountable to reporting that, it might inspire you to eat some broccoli. I don't know. But anyway, so free points, extra points just for tapping into that and taking a moment to write it down. And you're not going to get, you'll get full points if you just do it. Same with the clinical assignments. There's really no right or wrong answer. With some of the clinical things, I've been trying to give you feedback accordingly if there's something missed, but I'm just take a stab at this stuff and see what happens. So, and if you are behind, it's okay. The points are going to be given to you on the last day of class. So if by the date of the final, you turn in a full log, even if you've missed a few weeks, you're still going to get full points for that. So, and it's up to you, if you just pull something together and it's not as honest as maybe it otherwise would be if you're tracking it as you go, then that's, only you'll know that. But that's not for me to judge or decide. And also, again, with the examples I gave you, I kind of was specific about miles, and not everybody has a Fitbit or Strava. It doesn't matter, just kind of quantify it like, oh, I walked for 20 minutes, or I walked for an hour, or whatever quantify it however you want, document it however you want. I give you the template, but some of you have made gorgeous templates and you've made it your own, and that's great. So again, free points. So yeah, the test, again, I think you all did really well, and I'm very proud of you. And I think that, even if you didn't do as well as you had hoped, or if you felt like it was hard, that's not a bad thing, right? We're primary care providers, and we need to be held to, at minimum, the standard that was on that test, at least in this subject. So again, no one's going to fail on my watch, but it's going to be because of your efforts, not because I'm going to pull anyone through without earning it. So if you need help, I am so here. And don't be ashamed. Don't be embarrassed. You can come to me, via email or off the record, and I'll give you some pointers. And I will tell you, I mean, it wasn't until I actually started treating people and seeing these things in the context of my own patients and in the clinic that I started to get it. And even then, I had to think twice about, what to test for and how to test. And in the real world, if some of this information becomes dusty, you can look it up. And it isn't until you see several knees and several shoulders and several hips and several ankles that you're going to get comfortable. So don't feel bad. Don't put pressure on yourself to have to memorize it all and be an expert after this class, but I want you to have a really thorough grasp so that at the very least, when something comes up, you have some sort of memory in your mind, like, oh yeah, I remember that, or I heard about that, and you'll have some frame of reference, because there were plenty of things I was like, what is happening right now? What is this? and that is true of a patient as well. And I think most of you who have seen patients know that we can study things in our textbooks. This transcends ortho, TCM as well. You know, we learn all these patterns. We learn what kind of signs and symptoms to look for. In this case, we learn our ortho tests. We do them, and you're still scratching your head, and they're inconclusive. And what you think you might see isn't exactly what you do see. So, I mean, people in real life are going to present in all sorts of ways, but if at least you can sort of narrow it down to a handful of highly educated guesses, and start to peel back some of the layers accordingly, then you'll get there. And again, I think ortho's so important, whether or not you go on to explore this further. One of the reasons that I really became drawn to this is because acupuncture shines at pain management, and it's great at internal medicine as well, but it is so good at reducing pain, restoring range of motion. I mean, manual therapies, massage, all of those things are wonderful too, but we have this tremendous ability to take a little needle and reach places that we might not be able to get to with our hands. And just yesterday, I got a text from a patient. She's had 2 really difficult childbirths. Her pelvic girdle, which we're going to talk about today, but her hips and SI joint and the whole pelvic girdle has just been subject to so much trauma and change, right? And sometimes when we go through, whether it's childbirth or an injury, our anatomy changes and it shifts, and our soft tissue has to catch up to that, and our muscles have to re-educate themselves. And we develop scar tissue in really deep places. And so, this was a situation where she hasn't been able to sleep on her side for 4 years. She can't walk or run any significant distance without causing a huge flare in the hip. She's done countless sessions of physical therapy. She's in amazing shape. She's very, very strong. And yet she's still in excruciating pain, decided to try acupuncture. And after one treatment, similar to what the things we're going to talk about next, she instantly, she was able to walk all day yesterday without pain and sleep on her side for the first time in 4 years. And she just couldn't believe it. And it's not, it's not me, it's not you. I hate to break it to us, this is the medicine. It's our needles, and it's our anatomy, and how we decide where to put them, and how to restore chi and blood to, again, really deep places in the body that are difficult to reach with our hands. And so strengthening isn't always the thing, Physical therapy is a wonderful partner to acupuncture. And sometimes if I hit a plateau and the patient starts physical therapy, that'll kind of push them into the next phase of healing, and vice versa. More often than not, I've seen patients who have done a lot of physical therapy and have hit a wall, or it hasn't helped, or in some cases, unfortunately, it exacerbates the pain, because and this is very true of a lot of the anatomy we're going to talk about today. When you overload a muscle and you're constantly asking it to work, sometimes, you know, we know that we respond to repetitive strain or even injury by sending a bunch of chi and blood to that area, right? We've got to move that joint. We've got to engage those muscles. So we send chi and blood there. And we have our veins and we have our arteries and we have all these amazing, this incredible network of circulatory tissues that bring chi and blood to those areas. But then we have the capillaries that sort of branch off of that and allow extra chi and blood to reach the periphery, right? And those little capillaries are small. They are, if they get clogged, you know, it's not a life or death situation. They are unorganized. They're not as certainly more disorganized than our arterial and venous network, right? So they're just kind of this like spider web of blood vessels. And so it's very, very intuitive and obvious that over time, those capillary spaces are going to get congested with stagnant blood and inflammatory chemicals. We're going to develop gristle in these pathways, right? And we're not going to be able to fire the muscles in that specific segment of wherever the blockage is. So you'll have a situation, this happens in the glutes a lot, where, you know, the primary mover is working really hard. It gets overworked, over fatigued. Maybe you're going to PT, you're working it more. And then, you know, you hit a wall there because you can't fire the whole thing until you come in and smooth it out, right? Cupping, gua sha, acupuncture, e-stim, all that stuff. That's why we turn red when we cup and gua sha. We break up all those capillaries and instantly restore fresh blood, oxygen, chi and blood to the area, and we can fire those bases immediately. So that's another reason why acupuncture and PT are so great together, because while you're strengthening muscle groups and encouraging them to continue to move, you're also kind of smoothing out the pathways that are required for those to fire. Does someone have a question out there? Okay. All right. So I think we talked about all that on day one of this class, but I think it's appropriate to bring it up again for a number of reasons. So yeah, I think again, the next chunk will be better. I think we can take our time. I've allowed the hip and pelvic girdle to kind of bleed over to next week. And then we'll start the knee, and that's a big joint too. So that might kind of teeter 2 classes as well. And then we'll bring it all home with the foot. If we have some time before the final, we can just dedicate to a review. And for those of you who have this question, the final is not cumulative. So I won't ask you questions that you've already had. Sometimes, you know, and I don't know if I'm going to do this, so don't get angry if I do, but in other classes, and I think this carries more weight in review and assessment, there are some questions that a lot of people get wrong. And so I like a chance for redemption. So sometimes I'll give you the exact same question for an opportunity to, you know, get it right and prove to yourself you learned something, right? So can I ask, because I can't see what you all see on your end, and I grade tests a little bit differently. Especially if I have a short answer, I can't release the grade right away, and I like to give you feedback. So did everybody get their tests back, and did everybody get the feedback individually in that test that applied to you? Okay, good. I'm seeing a lot of yeses. Okay, awesome. So I just assumed you all got that, but if you have any questions or grievances about that, let me know. But let's see. I think we can jump into the hip. And we'll go more slowly, and I'm not going to rush. We don't have to rush. So, and you know, again, for the 100th time or more, thank you for being patient. The first go around with this class online, especially. And maybe when we're done with the hip, I'm thinking, and I welcome your feedback, and I have reasons for doing things, so I may reach the same conclusion, but it helps to hear what your experience is. So I might consider, because the first chunk, especially the spine, is so big, I'm considering separating the lumbar spine and plopping it into hip and glute. I don't know. So maybe after we go through it, if you're like, yeah, do that, let me know. Okay, so while I'm pulling up today's lecture that I actually made in black and white because just in case anyone's printing out there, I don't know. I don't want it to put you asleep, but I also, it occurred to me that some people might be running out of ink out there. So it might be a little more subdued. Okay. Oops. Okay, let me close a couple windows so that I don't freeze up on you. And we're going to, I would also like today to sort of break up our discussion and use that the Essential Anatomy Lab to kind of get a 3D sense, because there's some needling techniques that I've learned that don't really match even the Matt Callison textbook. And some of the needling techniques he uses, they take a lot of practice and supervision, I think, to reach like the psoas, for example, and iliacus. So some of you are going to get that, and then others maybe not. So there's some, all of this I think takes practice, but there are some safer ways to access some of these dusty corners that actually were shared with me. What's interesting about dry needling seminars that I know Anthony has taken many of in the past when we worked together, they are using different kinds of needles, and even in other courses that are more injection driven. If you ever get an opportunity to take some of those, it's actually really helpful because first, from a safety perspective, and we're using smaller needles, and we're not putting anything in or taking anything out, but just in terms of positioning people to reach places with accuracy without damaging structures on the way, a lot of those classes are pretty good for that. So anyway. Okay. So hip. And, I can't see you all. I trust you're here. But I encourage you, for those of you who want to, along the way, roll out a yoga mat or take your laptop on the ground if you're not already there, we can kind of go through some of this together. And I'm going to try to do that here on my yoga mat. So we'll see how it goes. I don't know. So hip, gluteals, pelvic girdle, really also the groin. I should have maybe said hip, gluteals, groin, but the pelvic girdle is very similar to the shoulder girdle, right? So we've got, the scapula is this bony prominence that has so many attachments to it, and it has to move in a certain way in order for the shoulder to function properly and in order for our posture to be most efficient. And the same goes for the pelvic girdle. And most people, when they come in and they say they have a problem with their hip, and I think I've mentioned this before, they're going to point to the outside of the hip. The true hip joint is the groin, right? So if someone, usually people don't refer to the groin as the hip, they refer to it as the groin. So there are it's in many ways such a better problem to have when the pain is on the outside of the hip, because there's a lot of gluteal muscle tissue there, and it's very forgiving and very treatable. And again, one of those situations where it's so deep, you're gonna, and depending on how much tissue is there, it's gonna be really challenging to reach all the way to the piriformis and massage it without bruising the tissue on top, right? And then if you do get to the piriformis, how much pressure and therapeutic value are you actually adding when you reach it? So anyway, okay, so we're going to spend some time on anatomy, and do not stress. I will be clear in your study guide about what you need to know. I want you to just don't think about a test. Just soak up the information and enjoy the amazingness of our anatomy and our body. Okay, so the pelvic girdle. There are three primary bones that kind of come together and form what we know is the pelvic girdle, right? So there's the ischium, or the ilium, sorry, which is there. That's the top of the hip bone, right? That's the zone where patients point when they say they have a hip pain. And the ASIS and PSIS kind of mark their anatomical landmarks roughly on the ilium. So we'll look at that in a second. And then the ischium is our sits bones, right? That's the bone that we sit on. And then the pubic bone, okay, so the ischium is here, right? The bottom. And then the pubic bone, or the pubis, is here. And so that forms, it kind of comes together in the front, and there's a lot of space there to move, particularly in women for the purpose of childbirth. And all together, they kind of form kind of like the glenohumeral joint forms for the shoulder socket. These bones come together to form the acetabulum, which is kind of similar to the glenohumeral joint, and that holds the head of the femur instead of the head of the humerus, right? And that's the hip socket, and that's here. So like the glenohumeral joint of the shoulder, the acetabulum also has a labrum. So The tears that we can get in the labrum of the shoulder are similar to the hip and knee too, the meniscus. So there's like these sort of connective tissue structures that are like a bowl, right? And if that bowl gets cracked, then we start to have, in this case, a labral tear of the hip. So the ASI, so this is from the side, this bone here, right, where I'm pointing to the acetabulum. So the anterior superior iliac spine, the ASIS, that's just to recap, those are those little bony prominences on the front of your hip, right? So I'm feeling mine now, and you can feel yours, and it's right in the neighborhood of gallbladder 27-ish. Just lateral to that. And then the PSIS is sort of the other side of that. And that is where, when we did the stork test, that's where we put our thumbs to mark the spot, right? So when we do the stork test and ask the patient to elevate their knee, we want to see our thumbs drop down when the knee goes up. I won't test you on that again, but it's going to come up here a little bit. So, fun fact. Just take a guess of how many different muscles attach to the ilium, that big hip bone. Does anyone have a guess? And this is such a cosmic number. Big hint. We see it a lot. Any guesses?
7, 5.
Ooh, I like it. More. 28. 28. Isn't that crazy? 28 muscles. So, I mean, no wonder. There are so many muscles that act. It's kind of like the shoulder. Like the shoulder and elbow are sort of synonymous to the hip and knee in the sense that we have to move the shoulder itself, or the upper arm, right? And we have to move the leg. So we're rotating at the humerus, and we're rotating at the femur. But then we have this elbow structure, and then we've got our knee, right? So all these pulleys, they just kind of attach in similar places, and it can be quite confusing, but it's quite incredible how many muscles attach just to the ilium, and we can reach it with our needles. And for those of you who forgot, just to remind you all, it's very common to injure ourselves in the wherever a tissue changes type. So in that musculotendinous junction where the muscle is starting to turn into tendon, right, where all those fibers kind of change type, that's where it's really vulnerable. So we can get in there mostly with our needles and restore and strengthen those attachments, and also restore qi and blood to those areas. So range of motion of the hip, so that we're speaking the same language. So flexion and extension are in the sagittal plane, right? So hip flexion is forward. Knee flexion is what this darker image is doing. It's a lot easier to flex our hip when our knee is also flexed. But if you have a straight leg and your leg and knee is fully extended and you flex your hip, it's harder to do that actively. If someone helps you passively, you can get it up normally. But you can experiment with that if you're laying on your yoga mat, or later on. Just try to extend the hip or flex the hip with a bent knee and a straight knee, and it's difficult. Extension is back behind you. So in most cases, extension is more limited than flexion. So adduction and abduction and adduction. Interesting. Well, this little picture, I'll try to doctor that up. That's adduction. I think that's hopefully obvious. I think it's showing by the dotted line and the red line, maybe both, but adduction is towards the midline, right? And we know abduction is away. So that's in the frontal plane that we're abducting the hip out or the leg out to the side, just like I'm doing with my shoulder right now or my arm. And then adduction is towards the midline. So crossing our leg would be adduction. And then internal and external rotation of the hip, those were always a little bit confusing to me. So again, the medial and lateral rotation is sometimes helpful, but you want, when you're orienting yourself to internal and external rotation, you want your attention to be on the joint that's moving, not necessarily on the limb or, whatever is following that. But if you tune your attention to the joint and let's say, I can't see myself. Let's see. So I'm going to stand up here. Okay. So, where'd you all go? Here we go. Okay. So, internal rotation of the hip, if you can see me, here's the hip joint. It's going inwards towards the medial, in the medial direction, right? My foot is going out, but my hip is going in. So that's internal rotation, and this is external rotation. So, your foot can go in front of you or behind you, but the hip joint is going out, right? Externally, laterally, and then the foot goes medial. But so again, it's not, that can be confusing. But hopefully not. So internal and external rotation of the hip. And again, if range of motion is a little confusing, just spend some time with it, because that's kind of the key to understanding how to do all the ortho tests and, what you're looking for later. And if internal and external rotation and flexion and abduction is like just a bunch of noise in your mind and you can't visualize that, then it makes it hard to put all the pieces together. So I just want to emphasize that for those of you who this is newer. And some of you already know this, and that's great. Okay. So this is just a summary. Don't worry about this. I'm not going to highlight any of these black for you to focus on, because secondarily, if you come back to this later after you've kind of studied what we're about to talk about, a lot of these will be familiar to you. Now, what's interesting about the hip that I want to point out, we're going to emphasize the glutes and some of the muscles in the trunk, actually, the piriformis or the iliopsoas, and the adductors. In the thigh, if you think about the quads and the hamstrings, those have largely, if we're just more broadly, those have more of an effect on movement of the knee. So we're not going to talk about all of the quads. I'm going to focus on the adductors because those have a huge effect on the hip and not as much the knee, actually. So it's interesting to think about this. And when we first take anatomy, we're just learning like, attachments, insertions, actions, innervations, and all of that. But when you start to break it down and think about body mechanics and how things hurt and where to put your needles in whatever structures you're aiming for, it's interesting to see these lines drawn between actions in muscle groups that kind of share the same neighborhood. So the only hamstring we're really going to talk about is the biceps femoris. Some of these are sort of super muscles, and they're like two joint muscles, and they maybe flex the hip and the knee. So you'll hear about them again when we talk about the knee, but we're really only going to focus on the muscles that actually move the hip itself. So, and this is not an all-inclusive list, but these are and there's a lot of crossover too. So again, I don't think it's very helpful to necessarily memorize this, but the wonderful benign side effect of learning some of these pathologies is that you will have memorized this sort of later, but I'm not going to force you to do that here because that's not very clinically relevant. The other thing is, and this is a slight tangent, but you should be used to that by now. And I kind of did this on the exam a little bit. When you're learning acupuncture points and point location, I don't know about you, but I think for myself and for a lot of students, when you're learning how to locate a point and the landmarks given to you are muscles and tendons and all of this stuff, that's not always helpful unless you know where that muscle is. And so that can be kind of noise, it's more, I think we default to memorizing points based on their relationship to other points and Sun measurements and really obvious landmarks, but like liver 11, right? Liver 10, spleen 12, those, when things start to come off the grid and actually start to follow anatomy in a curve, you start to, refer to adductor longus to locate points. And it's really helpful to know those muscles and know what they do and where they are, also in relationship to point location. And sometimes on a test, for example, you might get an easy question about point location, but it's not so easy because all you see is anatomy and you're like, wait a minute, what? Where is that point? So, sometimes muscles can clue you in, just the name of them on, where they are and what they do. So, an adductor is going to be in the inner thigh, right? And some muscles are named after the actions they do, like the opponens pollicis in the thumb. That is where long 10 is, right? So, if you just can kind of understand, they're getting some of the muscle names kind of give you a clue about where they are and what they do, I guess is what I'm trying to say. And they'll help you with point location and also point selection. If you're like, oh yeah, that point is on that muscle. Cool. Okay, moving on. So we're going to talk about the glutes. So super important. I can't tell you how often low back pain and hip pain is really a gluteal issue. And we have, just like, we've got these weak sort of mid-back muscles that allow the shoulders to slump forward, so many of us have weak glutes. And remember way back when we were talking about the lumbar spine, we looked at some gaits and some ways of walking, right? And there are a lot of patients, so you're gonna see right when they walk through the door, they're waddling into your office side to side, and they're loading joints unnecessarily because they don't have the strength and the integrity and all these little deep dusty places to kind of hold the posture. And they're, you know, our young places tend to get really tight, right? So the IT bands and lateral legs get very often tight, and then our inner thighs and adductors kind of get, the yin places get more yinny if we don't add more yang to them. So the knees kind of turn in, and so we'll talk about that too, but glutes are so important. So when you're out there doing your homework and walking around the world and moving, walk with your butt, you know, feel your glutes. A lot of them have external and internal rotation power as well as abduction power. And we don't really do a lot of activities that force us to walk sideways. We kind of walk, you know, in this forward motion, and our hip flexors sort of like drag us through the world. But these muscles, the glutes, have so many different actions in terms of stabilizing the pelvis. And if they're firing properly and they are strong, and I'm not talking about like Olympic strength, I'm just talking about like they're awake, you know, they're firing, they know what to do, they're not sleeping on the job, then the pelvic girdle is going to be more stable, and that SI joint is not going to slip around as much. So glute max, big strong muscle, we all know where that is. It's responsible. Think about this. This is crazy. And you can feel it too. If you stand up and just like do a leg lift in the backwards direction. Glute max it's a big hip extender. So it brings it back. It's an external rotator on part of its fibers. Covers such a wide area. That is going to go in lots of different directions and lots of different segments of those fibers, right? So it's an external rotator. It's also an abductor and an adductor. So that sideways action of the hip is definitely gluteal, not just maximus, but a lot of them. So the motor point of this muscle is just below UB54-ish, right around there. And there's again, the return and the therapeutic value on treating the glutes is so immediate. And when we talk about manual muscle testing in some of these areas, it's so amazing and wonderful to maybe test a muscle at the beginning of the treatment. It might be weak, treat it. And then if you have time and you think about it, test it again at the end of the treatment. And your patients will be so happy and amazed that all of a sudden these tissues are firing and they're stronger, and they might be a little sore, but they're stronger to move about the world. So anyway, 1.3 to 3 inches deep. I'll look that up. I might have meant to say 5. 1.3 inches seems really weird. You can go deep here. It's very, very, very forgiving. So, and then GB30 is also a good one, but the motor point of gluteus maximus, if you want 2 points to anchor to your E-stem, GB30 is great, but just, you know, right around UB54 or just slightly below is where you'll get that twitch response from the gluteus maximus. Medius. So we're getting deeper now. So here's the picture on the right of your screen with the little orange triangle. That is medius peeking through, right? So here it is on the other side by itself. So it's kind of under the lip of the iliac crest. And it's a hip abductor primarily. So like sideways walking that we don't really do. Dancing is so good. When we have a break in about 5 minutes, I encourage you to have a little dance party break and move your butts, rotate those hips if you can. Don't hurt yourself, but it's so, I mean, dancing is so therapeutic, and anything we can do to invite our glutes into our life is really a good thing. So, and yoga too, all of the wonderful things that I know you're all doing out there. So gluteus medius, I kind of think of this muscle, you can kind of access it, at the top of the glutes, it has that arc, right around the beautiful arch of the ilium. It's right below that, but you want to shimmy high enough up to get it. So this muscle, it internally and externally rotates the hip, but it's often weak just by nature of what it does. And there's 2 ways you can reach it. One way, it's the straightforward way. It's just 3 sun superior and 1 sun posterior to the greater trochanter. Sometimes, just depending on someone's body type, sometimes it's harder to find bony landmarks. But another way to find it, there's this, it's called the gluteal aponeurotic line. And if you just kind of palpate in that direction where I made this terribly crooked little white dotted line, if you palpate around there, you can feel that line. You can feel that little dip. You can feel the end of the glute maximus. And right lateral to that border, you're gonna be able to touch the medius. So that's a really good landmark too. You can kind of like shimmy around, find that little dip, and then needle right around that neighborhood. So formally, if you make a line along that that gluteal aponeurotic sort of little fault line, technically it's 2/3 up. That's the motor point, but any that's just a way to orient yourself. And you can do Usher points too, as long as you know where to palpate. And again, you can go pretty deep. You're gonna have to, especially if you're a little closer to glute maximus. You're gonna have to get past that and go to medius. Okay. Minimus. Oh, this is the culprit of so many issues. Again, it's very similar to medius in that it's a big hip adductor, so that sideways strength. It's an internal rotator. It's tiny and it's deep. So the picture on the right where I've highlighted it orange, it's right above the piriformis. So that's the piriformis. So we're getting like closer to the bone now. And these are the places, again, that are really hard to reach. You might reach an attachment closer with your finger, but they're hard to massage, right? So this is a pretty easy one to find. It's roughly in the neighborhood of GB29, but it's right on the lateral side body, the gallbladder channel. So you just find the top of the iliac crest, and then the top of the greater trochanter, and it's right in the middle there. So again, deep 1.5 to 2.5 inches. It's a really good one to needle. And then the piriformis. Ooh, this is also a culprit of so many issues. So right kind of below gluteus minimus. It's kind of like a pear shape, right? It gets kind of skinny by the bone, and then it widens a little bit and then gets skinny at its lateral attachment to the greater trochanter. It's also an abductor, but only when the hip is flexed. So if the leg is bent, it moves the leg out side to side. So there's so many activities that we do actually with a bent knee and hip in sports too, that kind of maybe will yank us laterally. And it's also an external rotator. But I snuck in, remember the sciatic nerve here, that huge yellow nerve. See how in this model, that nerve is passing right behind it. So we'll talk about piriformis syndrome, that controversial sciatica piriformis syndrome, lumbar radiculopathy. What the heck is the difference between them all? But this is another one that, by process of elimination, you can diagnose the piriformis, but it gets blamed for a lot too. But rightfully so, because of its proximity to that sciatic nerve. And it's a really tiny little space. And if this muscle squishes it, or again, there's so many different anomalies for the sciatic nerve in relationship to this muscle. It can pass through it. It can kind of, I've seen different pictures of it kind of going around it in a number of ways. I don't think it much matters. All we care about is how our patients feel, right? What do we care if the piriformis is, if the sciatic nerve is going through it, behind it, doesn't matter. If it's hurting, we'll treat it. And I don't think that those anatomical variations are necessarily going to prevent them from getting better. There's a lot of controversy about that too, and there's a lot of studies that have shown it doesn't really matter. You might be a little bit more vulnerable to sciatic nerve compression by the piriformis if you have an anatomical variation, but so in this case, and we'll talk about this later when we start refining our diagnosis, but just to recap, this is when you've got pain in the glute that refers to the thigh but does not travel past the knee. That's what you're likely to see in a, sciatic nerve compression by the piriformis. So this is a super easy muscle to find. It's just halfway between UB53 and 54. So over here on the left, I've got the two black dots roughly at UB53 and 54. And as you can see, boom, right between them is the piriformis. And, again, depending on someone's anatomy, sometimes you can feel a little more of like a hypertonic tissue right in that zone. But sometimes you can't because there's a lot on top of that. But you've got to go deep, 2 to 3 inches there. So, similar needle depth to what you might want to use on GB30. Okay. So let's see. Let me see here. You guys still with me? I think you are. Yeah? Oh, good. Yay. Hello out there. Okay. Maybe, you've heard me yap for an hour. Maybe, let me take a quick peek. Yeah, maybe we'll take a little break if you guys are ready for that, unless you want to go through one more muscle. I don't know. Are you ready for a break? Have I exhausted you already?
Yeah, maybe a little break. Thank you.
Sure. Yeah, let's take a break. And we'll meet back in about 15 minutes. So 2:45. Sound good?
Okay, thank you.
Okay.
Good.
Here we go. Sorry, I'm a touch late. All right. Where were we? We were talking about, let's see here. Let me share my screen. And again, close another window. Okay. It's, I'm sure you all struggle with this too, but to be in the classroom and use our cameras and have all these apps open, it just takes up a lot of bandwidth. So I feel my computer getting hot. All right. So back to the anatomy. We're talking about the TFL next. And the IT band. I kind of think of these sort of together because the TFL, the tensor fascia lata, it sort of, it's the muscle at the top of the IT band. So its connective tissue kind of forms into it, right? So it starts at the iliac crest and ASIS, and then it attaches all the way down to the tibia via the IT band. So the hunk of muscle itself on the side of the leg, the TFL itself, it really kind of stops right below like the bottom of the glutes. So that tiny chunk of muscle is pretty high up. And then the rest of it is connective tissue. So the TFL is a big hip flexor. Also hip adduction, so in the forward plane and in the side plane. And it's an internal rotator as well, a little bit. And, you know, internal rotation of the hip isn't like our hips. We've got the femur, and then it hooks a hard corner left and right into the hip socket, right? The head of the femur. And so most of the actions that really power us through the world are in the frontal plane and kind of side plane. But internal rotation of the hip isn't this like demanding action. And also, you know, it shouldn't be, because it kind of squishes the joint, right? So same with, like, you know, the pecs have a lot of power to kind of pull us forward. But, you know, if we're just kind of constantly sleeping on our arm like this and like squishing the shoulder into the socket and squishing the hip inward, we're going to load the joint a lot more than it will probably appreciate, and it may also start to impinge different nerve pathways. So, you know, just by nature, the external rotators are, and this is not one, this is an internal rotator, but when we talk about internal rotation of the hip, it's kind of like a, hey, P.S., I also do that too action. External rotation of the hip is, you know, the muscles that are responsible for that, they're like, I think, like 50 to 60% stronger than internal rotation, because internal rotation is normally like a secondary function of all of the muscles that actually do that. There's no like pure internal rotator. They all kind of do something else, but PS also internally rotate. Anyway, so the TFL, the motor point of the TFL, and the way we reach the belly of that muscle is GB29. I love that point. I use it all the time. It's halfway between the ASIS and the greater trochanter. It's also the crossing point of the yang wei mai, right? I know you know that, maybe. And you can get to it, you can needle pretty deeply there. I often treat points along the whole IT band as well. So 29, 31, right? 31 is the point that's usually marked by where the bottom of our hand kind of hits the lateral thigh. GB 32 and 33, those will all sort of get the IT band as well. But the IT band itself is pretty superficial, so you don't need to needle as deeply down below. But to get the TFL to participate in your treatment, you gotta needle a little deeper. So the IT band, just to kind of talk about what that is, we're all familiar with it, right? It's the biggest band of fascia that we have in our body. It's not a tendon, actually. Technically, we're not going to argue about that or call someone out, but it's often referred to as a tendon. But if you look at the structure of it, it's more like fascia. And, we talked about fascia at the very, very beginning of the class in the intro. And that fascia is kind of like this net that is sort of laid in sheets rather than like rope. And it kind of, when it's really healthy, it can kind of like mold to our movement and yield to our movement in a smooth way, like honey, right? So it can be helpful to think about what these things are. And it attaches all the way down to the master point of the tendons, right? GB 34. So that makes sense. I like to think of GB 34 not only as the master point of the tendon, but of the fascia too, the connective tissue, because it punctuates the bottom of the biggest band of gristly connective tissue in our body. So, you can invite that point into your treatment with any ortho treatment where someone's kind of tight and they've got, that kidney, liver, yin deficiency and, sort of tension and dryness and brittleness in the tissues. Yeah. So with the TFL, the IT band kind of helps abduct, flex, and internally rotate the hip. So there it is. So fascia, just to refresh your memory. So it's the sheath, right, that encloses and compartmentalizes muscle. We talked about the analogy of like the little thin membrane around chicken or eggs, that eggshell membrane that kind of when we peel a hard-boiled egg, we kind of peel that away too. It's in contrast to tendon. They are sheets that are sort of separated by hyaluron, yin, liquid, right? And so they kind of like, fascia is designed to kind of slide around, where tendon is really supposed to anchor the muscles where they're supposed to be. They don't really like to stretch and move as much, maybe, as fascia does. So in a healthy state, that fascia is going to slide and move with us. And in an adhesive state or a yin deficient state, that can dry up and tighten around muscles, right? Like that saran wrap. And when it starts to kind of squish them, it can really change the shape of the muscle. You can feel like all these like gummy little adhesions, and that can entrap nerves. It can interrupt how smoothly the muscle can fire. So fascia is a really amazing tissue that is everywhere in the body. And we have a gigantic effect on it with our needles, no matter where we put one. So let's think about the sinew channels now. And when you're doing Usher points, you know, oftentimes that's kind of what we're treating. The sinew channels, as you know, are wider than some of the other pathways. So there's a lot of crossover when it comes to our channel anatomy, but there are two major sinew channels that come to mind, primary channels, when we think about, I think, the glutes. So what comes to mind for you? Let's see. Okay, good. Sorry, now I see the chat. UBGB, yes, good. Yep, absolutely. So we've got the UB or the GB sinew channel and the UB sinew channel, right? So the UB goes right down the back through and binds at the buttock, right? And then it continues down. It kind of follows that sciatic nerve pathway that we looked at earlier, and it kind of stabilizes the lumbar spine, the sacrum. But then the GB channel binds at the sacrum too, right? And wraps around the hip and the side body on the outside, right? So this is sort of the yang part of the hip, I guess you can think of. Okay. So now we're moving into the more yin areas, but the sartorius, that's a crazy muscle. It's so long. It attaches all the way up at the ASIS and then goes all the way down to the medial tibia, kind of around like spleen 9. And, you know, that's a huge pathway, just like the IT band is, right? The sartorius, it's interesting. So it's kind of on the medial, it kind of wraps around sort of the yin side of the leg. But it's not really an adductor. It's an external rotator, an abductor, and a flexor. And so it has a lot of that like outward yang action for being in such a yin place, which I think is really interesting about the sartorius. And because it's so big and long, I guess maybe big isn't the right word, but it's a longitudinal muscle. It's got 2 motor points. I mean, if I'm aiming for that, I'll kind of, you know, I might do some Usher points along that muscle as well. But when the knee is flexed and when it's bent, kind of like the piriformis has this extra action when you all of a sudden bend the leg. But in this case, the knee, it can internally rotate the tibia. So we might talk about that more when we talk about the knee. But it's a big rubber band that essentially crosses a huge area of the thigh. So it's a good one to know. And it's right, we can access it kind of right below stomach 31. But what you want to do, stomach 31 is kind of at the top of rectus femoris. It's pretty easy to find because there's a big kind of like chunky prominence there in the hip flexor area. And you want to kind of slide one soon down, but medial to that. And then you'll start to feel the sartorius. And it kind of starts to curve around. So it's one soon below stomach 31, but you have to kind of like swirl around too. So you kind of want to follow that pathway of the muscle and palpate for tender points. And then the second place to access it is spleen 11, which is just 6 and up from spleen 10. And you have to kind of go far enough up above spleen 10 to actually get it. Otherwise, you're going to hit vastus medialis and Baichung Wo. So that's kind of like, you can kind of orient yourself that way. You can slide up from spleen 10 and kind of palpate and find it from the bottom up, or from stomach 31 wrapping medially from the top down. Okay. And then rectus femoris. This is so satisfying to treat, this muscle. It's a gigantic hip flexor, and it also extends the knee. So I mentioned that earlier. It's one of those like 2 joint muscles. So in the context of this segment of our of topics, we just are going to think about it as a hip flexor. So when the glutes are weak, we're going to just default to using rectus femoris to move us about the world, because it's such a big, powerful muscle and it propels the leg forward, right? So it's often very tight. And the motor point of that is stomach 31. So that's the white dot at the top there. And then you can access it further down. And if you just find the upper border of the patella where extra point Hading is, go right between stomach 31 and Hading, and it's right there. Very easy to find. You can needle pretty deeply there too. It's very forgiving. So the adductors, it's kind of the last group of muscles I want to look at. And I kind of want to look at them just all together. We don't need to necessarily pick them all apart. But if the muscle starts with adductor, that should clue you in on the fact that it's, the location of it in the inner thigh, right? Some names deviate from that. Pectineus and gracilis do. But this kind of group of adductors, you kind of, they all adduct and like cross the leg over, essentially. But, and they don't really have so much of an effect on the knee. But each of them, although they all kind of adduct to the leg and cross the hip towards the midline, they each kind of do something a little bit differently too. So when someone has an adductor strain and pain along that area, it's helpful to kind of be familiar with them, because some of them, so that pectineus, for example, it adducts and crosses the leg, but it also flexes the hip. So the pectineus is here. This is the top one. And the motor point there is just sort of below and slightly lateral to liver 10. So liver 10 is about here where this green point is. So pectineus is at the top, kind of shimmying over from liver 10. Adductor brevis is behind all of that. So we're going to look at this in 3D in a minute, but you can kind of sneak into that one too. It adducts and flexes the hip. So it's another hip flexor helper. There are so many more, there are stronger hip flexors. So adductor brevis, we don't need to worry too much about it. It's usually not the culprit in isolation. If someone has a problem with flexing the hip, we're likely going to treat other structures, but it's along the pathway. So oftentimes when I'm treating the adductor groups and I'm feeling around, there's not a ton of traditional points along that pathway. So it's kind of nice to know what you're needling as you're palpating around and finding all these hypertonic muscle structures and Osher points, just for sake of charting. too. But brevis is kind of behind there. The brevises are like, they tend to be like tiny little deeper muscles. Adductor longus is the next one down. That's an adductor too, and externally rotates the hip. So it crosses and uncrosses the leg. And that's 3 cun below and a half to 1 cun lateral to liver 10. Adductor magnus. That adducts and extends the hip. There's 2 places you can reach that muscle, and one of them I kind of have it's above the arrow, and it's this sort of gray dot here you can see. I don't know if you can see my cursor, but it's the grayish kind of lighter dot above the arrow to the muscle. And that's implying that you got to go through longus to get to it. So it's a little bit deeper. And then gracilis is the inner thigh. That adducts, flexes, and internally rotates the hip. So, hip flexor injuries, they kind of drag along a lot of the adductor groups as well. So it's just when we're picking apart the thigh and looking at its relationship to the hip, the adductors have the strongest effect on the hip and not so much the knee, right? Because it's going to kind of control this like rotation in and outward. So there's a lot of sinew channels there, right? Or there's a lot of like acupuncture channels there, are yin channels. This is a very yin area. So there are 2 primary sinew channels that I think about. And I'm going to, let's see. I'm going to find the chat, see if anyone has any guesses on this one. So you said GB and UB for the, yeah, okay, yes. Spleen is part of it. That is true. I will give you that. Yes. So, but these are the 2 that I kind of think of primarily. So this one on the left is the kidney, and this is the liver, right? So kidney, liver, yin deficiency. The spleen definitely is part of this. And, the spleen is interesting because it kind of continues along. I'll pull up the sinew channel for the spleen too, because you're right about that. But the spleen kind of, I think of that too as like the deep abdominals as well. Because it starts to kind of creep up and connect to the core. Okay. So, and speaking of which, this is such an important muscle group to talk about, the iliopsoas. The iliopsoas is formed by the psoas major and the ilium, right? So there are 2 muscles, one of which, the psoas, it attaches to the anterior portion of our lumbar spine, starting at T12 and continues all the way down to L5. So it's behind the abdominal muscles, right? And in the front of the lumbar spine. And then it threads through the pelvis and kind of hooks around, makes a curve in the bowl of the ilium on the inside. And it attaches to the lesser trochanter of the femur and the groin. So a lot of times, like, as we know, pain is likely to present along the attachment sites. Low back pain that kind of refers to the groin. You've got to kind of rule out a true hip joint issue, but the psoas is a very common muscle to be weak. And that is a common pattern to discover as well, like the low back pain with the sort of referral to the groin, the attachment. And the psoas and the iliacus, aka iliopsoas, is by far, those are the strongest hip flexors. So that's why I'm talking about them here and not necessarily in the low back. So that's important to know. Rectus femoris is probably the next strongest, but that's more of like a kicking action, right? Where because it also it hinges at the knee. So the psoas is and the iliopsoas, that's the second muscle group you want to think about in terms of hip flexion, but more hinging from like the lumbosacral spine, right? So when we flex forward from like what we know as the low back, we're also flexing the hip, right? And then when we kick our leg and lift our leg, we're also flexing the hip. So from that low flexion point of view, you want to think like rectus femoris being the primary player, and then leaning forward, we want to think of iliopsoas. And this muscle is talked about a lot. It's very emotionally charged. And when we have a lot of trauma and we like want to curl up in that fetal position and like kick our legs up, as we often do, and we sleep in that position too, that muscle contracts and it can fatigue, can get full of gristle just like the other ones. But it's responsible for flexion of the trunk, which also involves the knee, or sorry, the hip. I heard a little something.
I had a question.
Yeah.
Yeah. So do you see like a lot of tension in this muscle for people who maybe have like kidney yang deficiency because of its association with the lumbar and the like kind of curling up?
Mm-hmm. Yes. Very, very, very good observation and good point. Absolutely.
Okay. And then I was also curious, do you see it like a lot with people with spinal stenosis who kind of tend to hunch forward because that's like what's more comfortable for them?
Definitely. Yeah, there's a lot of things about spinal stenosis that I mean, some of those really deep sort of like issues on the bone level, like the kidney level, that change our anatomy. Yeah, that definitely, things like that tend to make a lot of different muscle groups suffer and work harder to maintain integrity of our spine, because we are designed at all costs to protect our spine and remain upright, even if it means that we like curl around and twist in all these interesting directions, like a tree trunk growing towards the sun, right? So you're going to see the answer is yes, yes, and yes. And you're going to see the psoas implicated in a lot of things. And so it's just good, even if no one's there to answer the question, that's the way of thinking that you're going to want to do in the clinic too, when you're talking to people about, everything in their life, emotionally, physically, the way they're sitting, the way they're carrying themselves. Those are the kind of things in the back of your mind you're going to want to start. Oh, okay, let's check the psoas, or we're going to talk about how to get to it, because again, it's one of those muscles that is so difficult to touch. In a massage, it's a very uncomfortable muscle to reach. And those of you who give and receive massage, who have maybe had your psoas treated, it's a sensitive area to go to the attachment in the groin. So that's also an area that is guarded too, right? And then if you go in kind of through the abdominal wall, that's also like really uncomfortable to have someone push that hard on your stomach. So we can reach it from the gallbladder direction on the side very easily. And I've tweaked, I've had psoas or iliopsoas issues and sacroiliac joint issues also. That's another really, really big one. Those go very, very, they're very closely related. And so I would definitely, if you're treating the psoas, you're going to just want to treat the SI joint as well. But I have had, we were talking about this maybe I think just yesterday. This is such a deep place, and I've injured it several times, in dancing, running, whatever. And along the course of receiving treatments to reach this area, whether it was in school practicing or just, making an official appointment in a clinic. This is the first time I had this point needled or this muscle needled. It was one of those experiences that we talk about where someone like reaches so deep down into your body that it like transcends the physical plane and just pulls out like years worth of emotional stagnation. And people can have like a tremendous emotional release with this muscle. It's like I said, very emotionally charged. And it was the first time and only time actually since I've ever like cried, not because of the pain, and it was very surprising. I was like, what? Where is this coming from? Like it was an interesting experience, and I'm really grateful to have had it because it's unique. And it's I think we've all kind of either experienced or been witness to that, and if not, you might be. But it's a good muscle to assess and consider, and it's easy to test. And but it's a very deep treatment. So if somebody comes in and they are, relatively fragile, you don't necessarily want to just go for the dymite. Exactly. So I would start there, Sebastian. Good. Sanjo 5, gallbladder 41. That is a tremendous pair distally to release the and treat from a distance the SI joint and the iliopsoas. So that's, I would, as long as you can reach them or at least one side, I would include that in your treatment when you're considering the dye, which we'll talk about some of these extraordinary channels in a sec. But yeah, it's a strong treatment and it's a deep treatment. 26, 28, and liver 14. These are great. Yeah, absolutely. 26, 27, 28, and liver 14. Yes, I agree. So I would encourage you to experience this treatment. I'm happy to, anybody who wants a psoas treatment, let me know. You might have to wait a little while, but it's really, it's an interesting experience, and I encourage you to do that because you're going to want to treat it at some point, I'm sure, along the way, but it's good to feel what that feels like, and it's strong. And so you want to be able to assess and have that wisdom in your mind to assess, okay, can this person handle it? You can do it gently, and it's really not as bad as it sounds, but again, just it's so powerful. It is such a deep place in our body, and subject to a lot of stagnation on the physical and emotional plane, and also just very difficult to reach with a hand. So a needle, perfect. Got to use like a 3-incher though. So we'll talk about that. All right. So, yeah, that's the psoas. And then the iliacus is a little shorter, and it's on the inside of the ilium, in the iliac fossa, and the inner lip of the iliac crest. So you can sneak around there from GB27 if you orient your needle right. But you gotta, you know, if anyone has a clinic with Marquetta, you may have an opportunity to practice this. She often will needle the iliacus, and you got to curve your needle kind of around the bend there towards the iliac fossa. So it's tricky, and you want to be careful. You use a thick enough needle, and you're not going to bend it or break it. But yeah, it connects to the lesser trochanter of the femur via the psoas tendon. So they together sort of they converge to form the iliopsoas in that deep place of the hip and sort of attach together on the lesser trochanter. So the greater trochanter, we know where that is. That's easy to find on the lateral side. But if you reach around towards the groin and kind of like palpate the lesser trochanter, that's a deep and very kind of delicate, sensitive place. So that's again how it's often reached with massage. You can certainly needle it there, but there are more effective places and less sensitive places, I think, to reach it, and unless that's an appropriate direction based on the situation. So, and with everything, you know, you've got to be really, really mindful of people's comfort level, their sensitivity, the draping techniques, all of that. I mean, yeah. Okay, so the iliopsoas, here it is. So what channel pathways do we think about with this one? Give you a hint. I'm going to pull some up. So, oh, look at all that threading through it looks like the anterior portion of the spine, around the hip. Oh my goodness, back and forth and all around through the abdomen. So here's the liver again, the gallbladder, the UB, and the kidney. So all of the ones we just talked about really kind of like come together to form the iliopsoas. And you can argue, I mean, there's so many ways to reach this, but that's just the way I kind of think of it, right? So we've got the really yin-y aspects of the kidney and liver, and then we've got the really yang aspects, you know, of the UB and gallbladder, but gallbladder Shaoyang, right? So it's kind of in the shadows, half in, half out. Yeah, so when we think about the extraordinary channels too, here's just, and this is by no means a comprehensive list, but so some of the pathologies for some of these extraordinary channels: pain in the genitals and groin, which you could certainly have with an adductor strain, an iliopsoas strain; contracture of the sinews, which is also the case on both of these, contracted sinews, contracture of the sinews; flaccidity of the muscles on the lateral leg, and tension on the medial leg. So that's an interesting dynamic. So there's that extraordinary vessel, right? And then on the flip side of that, we have aversion to wind, right? And hemiplegia. So a lot of vulnerability to liver wind, which has a huge relationship to the tendons and also our neurological stability, right? Chronic painful obstruction. Oh my goodness, that's everywhere. Rigidity of the body, stiffness. Who doesn't have that too? Lumbar pain, contracted sinews, and this is all so much more common. Flaccidity of the muscles of the medial leg and tension on the lateral leg. So weak adductors, tight IT bands. So these two, you said it. I heard you in your mind. the yin chow mai and the yang chow mai, right? So these relationships. So kidney 6 and UB62 are wonderful points. You can invite their buddies as well. So lung 7 and kidney 6, especially if you're treating a woman and you're also talking about the menstrual cycle and you want to treat the Ren. And you know, that's just a more yin extraordinary channel. And then very commonly the yang chow mai with all of these things, UB62, and you can certainly invite its buddy SI3 to treat the spine. And those are great pairs. You can do kidney 6 and UB62 together, which I often do. Sometimes even if I mean, and this is the beauty of TCM. I mean, how lucky are we to be doing this, right? Even if somebody just needs a little Shen circle, or I shouldn't call it a little Shen circle. Shen circles are no little thing. But even if you're giving somebody just sort of a balancing treatment on the back through the shoe points. And with ortho, you have to be so sensitive to what somebody needs and can handle. And you don't always need to go straight for these tissues and motor points and hook them up to e-stim. I highly suggest you know how to do that, though, because oftentimes that's what's needed to get over the hump, especially with athletes and in sports medicine and people that have more young and have a lot at stake too, and getting back out and doing the sports or the activities they love. But when someone's teasing through the complexity of an injury, or maybe it's a car accident, or there's a lot of emotional trauma involved, or they need a more yin kind of balancing treatment, right? We treat the yang to treat the yin, and then maybe you just do some delicate points along the UB channel, but then you add kidney 6 and UB62 and SI3 and maybe lung 7 to balance these structures too from a distance. And that is often a very effective treatment as well. So, now, yeah. The Dai Mai and the Yang Wei Mai together, oh my gosh, that's the epitome of pelvic stability and motion, right? So the Dai Mai wraps around, as we just talked about it. So yeah, all those points, liver 13 or 14, 26, 27, 28. Sensation at the waist as though sitting in water. Remember that? Like that heaviness, that kind of like, it could be weakness too. Dampness, right? And then pain around the umbilicus, abdomen, waist, and lumbar spine. That is very, very psoasy as well. And then the Yang Wei Mai. Acute sudden pain and swelling of the lumbar region and dyspnea with raised shoulders. Okay, maybe that's referring to asthma and implying coughing, right? Because of like the diaphragmatic movement of not being able to breathe. But think of that implication in relationship to that, that upper cross syndrome, or what, we talked about early on when there's that sort of like sympathetic stress mode where someone's just breathing with their neck, right? And they're not sinking their breath down to the diaphragm and deeply to the abdomen, or breathing through kidney 1. Like everything is just kind of stuck up here and their shoulders are raised, I mean, that's also what I think of too. So again, I cannot stress how powerful gallbladder 41 and Sanjiao 5 can be. Truth be told, when I'm needling somebody orthopedically and they're in all sorts of tough positions to reach, especially in prone position. I can't always reach Sanjiao 5. And, you know, when I have, I like to, if I can, I really like to have the patient be able to control their own electrical stim levels. It's easy to do. They're not going to do, you know, any damage if you orient them on what to do. And they're going to be able, if you walk them through, okay, here's this button for these needles, you know, if you walk them through how to set their levels on that electrical stimulation unit, they're going to be able to get it up much higher when they have control over it, rather than if they're kind of like anticipating and holding their breath and waiting for you to do it, right? And some people really love it. They stay engaged with their treatment the whole time. So we don't want to move the hand and the wrist with Sanjiao 5 in there, right? That's asking for a bent needle, and it's just painful. So it can't always reach Sanjiao 5, but if you can, and if you can thoughtfully position the patient to be able to reach those points, at least, like I said, on one side, super powerful and really, really great. So I wanted to just refresh your memory on upper and lower cross. We talked about upper cross. I'm not going to focus on that. But this slide comes from way back when, right? So lower cross syndrome, to refresh your memory, it's a significant contributor to low back and hip pain, just as upper cross is a significant contributor to neck and shoulder pain. Most people have this, and, you know, to some degree, if not one, both. So we know what the upper cross syndrome looks like, right? That that overemphasis in kyphotic posture, just kind of asking for the kyphosis dowager hump, right? And then lower cross syndrome is that sway back posture. So, and that's, you know, not as commonly talked about or identified, but, and harder to kind of see, but, it's really, really super common in low back pain to have the punchline here. If you remember nothing else, low back pain, the perfect storm for low back pain is hypertonic hip flexors, particularly the biceps femoris, and then weak gluteals, right? So if max is weak, minimus and medius are going to be weak too. So it's that, you know, sort of like forward pull from the hip flexors, and that weakness from behind, just like that weakness in the mid back, fails to sort of like keep us upright and oriented. And when that fails, the pelvis can kind of tilt in all sorts of directions. And if that's only happening on one side, the torque in the pelvis can stress the SI joint, and you're going to see all these like contralateral patterns. And I see all the time when I'm assessing the hip or low back or any issue in this area, I often see, and I don't know if it's 50% of the time, but I'm inclined to say that because I see it often enough in certain patterns. I can kind of get a sense now and predict it, but I'll see the opposite SI joint be fixated, right? Or out, right? It's not moving in the right direction. So the SI joint is stuck or malfunctioning on the opposite side of the pain. And that's super common. So, yeah, weak glutes, tight hip flexors. And the third thing, the third big punchline, is a weak core. So core strength is also like the core and the glutes. Those are two major areas to strengthen that don't get enough attention. And it is like a savings account if we start now towards buying us years worth of comfort and stability in our low back and hip. So, all right, I think, okay, let me see. Okay, so All right. I'm gonna give you guys another break, but I wanna address the chat real quick. Pushing the intestines out of the way. Yeah. Okay. That is that's a strategy for sure. And Frederica, you are absolutely right. So it's much safer, and I'm think, you know, a lot of you may have seen this either in clinic with Anthony or Marquetta. I can't remember how Marquetta needles the psoas, but side lying, absolutely. Now that goes with your comment, Sebastian, too. When you're laying on your side, the intestines are going to be pushed out of the way because gravity is going to pull them down. And it's not just the intestines, it's the kidneys. We don't want to needle a kidney by accident, and we're in that vicinity. So, you know, when someone's laying prone, gravity's pushing everything up further towards you. It's not, I mean, the pressure on the table is not doing you any favors and moving anything out of the way. And I just I think there's a lot of risk there. If someone's really thin and you can clearly see your landmarks, that's good, but you also don't have as much room, right? And if someone if they have more tissue to get through, you can't really always necessarily see or feel where you're going. So I just think side lying in 100% of the cases, if you're going to needle the psoas, is so much safer. And oftentimes one side is affected. There is definitely there are situations where you'd probably want to treat both sides, but you either do it in 2 sets and needle one, let them rest, flip them over, do the second side, or just do one at a time. And I like that actually, because a lot of times you'll treat someone and then they'll come back and they'll say, oh my gosh, my good side now, you know, feels worse than my bad side. And it also really allows the patient to feel the difference between both sides of the body. So I think, you know, if you're wanting to just say hello to those areas energetically, the like Mingmen fire kind of rogue way treatment of like UB23, 52, and do 4 line is great. Maybe even sneak around to GB25. But, you know, if you're really going to go for the psoas, which I'll show you in a minute in 3D, side lying, definitely. So yes, Frederica, you are right. All right, ready for another break? Let's see. So let's come back. Again, let's take, I think we can do another 15. Let's just come back at 5 minutes to 4. Okay, 3:55. Okay. Thank you.
Hey, Jen, I want you to have a break too, but I wanted to tell you,
Yeah.
I asked you the question about, is there an advanced trauma in orthopedics? And
Oh,
there is.
there is. Oh, thank you.
They're
Yeah.
offering it this trimester coming up,
Oh,
and it's an
good.
elective.
Oh, good.
And
Wonderful.
I'm totally taking it.
Oh, good. Yay. Excellent.
So,
I'm so happy that that's available to you all. Yeah, it was at the time when I was a student too, and there's like a trauma and ortho certificate you can get too. I think it's like an elective. So, yay, good. I'm happy. I'm
me
happy
too.
you're inspired to continue.
Well, my neck did that.
Yeah. Well, that's often the way it is, right? Our own injuries will lead us down these wormholes, and that is the biggest blessing for all of our ailments. They teach us so much. So thank you, neck.
I'm not ready to say that, but I am excited about because it definitely did open up a field for me that I really hadn't entertained. So
Yeah. Well, good. Good, good. And again, you don't have to specialize in it, but put it in your like secret ninja like skill box. That's not a thing, but you know what I mean? Like you can specialize in something else and like lead with that, but then, inevitably someone's going to say, "Hey, by the way, my back hurts." And you can be like, "Oh, does it now?"
Mm-hmm.
Well,
For
then.
sure.
All right. Thank you, Amy. I'm glad you mentioned that, and hopefully everyone heard that, and that many of your classmates will be joining you. So good.
Cool. So yeah, just saying, don't sit down for our whole break. You go exercise
Oh
too.
yeah, no, and I'm gonna get down on the ground. I think I'm gonna attempt to. I'm gonna shimmy around my camera and see and try to like manual muscle test myself. We'll see how this
Nice.
goes. I don't know. Anyway. Yeah, okay, good. Oh, I'm glad a lot of you are maybe taking the advanced T&O. That's great. And I'm so happy to hear that. So good. Woohoo. All right. Have a good break. See you soon.
Okay, you too.
All right, I'm back. I'm gonna stand for a little bit here. All right, let's, before I jump back into our PowerPoint, I want to look at some of this anatomy we just talked about in 3D and just talk about these planes of motion again real quick. So hopefully I don't freeze on you. And if I do, I'm sorry. And let me know. Give me a shout. Okay, so here's our friend again. Hip flexion. We talked about the rectus femoris here being like one of the most powerful hip flexors. It's one of the strongest hip flexors. And you know, one thing I'll say about this app, it's interesting. The info here, when you look at like the actions and sometimes the actions of a muscle are a little bit controversial, and some sources will include like all these different actions that can possibly happen from all different sorts of muscle fibers. And then other sources will kind of simplify it into like the big kind of major actions. Don't be discouraged. And this happens a lot in trauma and ortho. If you run into a little bit of if one source says one thing and one source says another, I think for the most part, the takeaway here, rectus femoris is a hip flexor, but it also, it extends the knee as well. And when you're thinking through a muscle too, remember muscle tissue, when it contracts like a rubber band, but like a reverse rubber band, kind of, those fibers get closer together, right? So if even on a test question, let's say you get a TNL test question on your boards and you're like, oh my God, that was so long ago, I don't remember what muscle does what. Think it through and move it on your body and like visualize fibers coming together and tightening, kind of contracting, to shorten the length of it, right? In order to act on a joint like a pulley. And when it lengthens, something else is contracting in order to move, right? So just remember how muscles behave in their elasticity. So now, let's see. I want to show you. So deep in here, let's look from behind. We've got, well, okay, so we just talked about rectus femoris on the front. So there it is. And then biceps femoris, it's sort of the antagonist on the back. That's really commonly injured. And this is more of a knee joint muscle. So we'll talk about that more later. But that also helps to kind of extend, as you would guess, right? The hip brings it back. But if we kind of go deep in here and take away as many layers as we possibly can, here is our friend, the psoas. So here's psoas major and here's iliacus, and together they form the iliopsoas. So it's two muscles. And one muscle I didn't talk about, I keep debating, is the QL. The QL is right here, quadratus lumborum. We could have talked about that in the low back segment. It is a muscle that does this. Oh, can you see me? Yeah, it does this, right? Lateral side bending. It's really easy to get to it while you're in the neighborhood of the psoas. So and this our friend's arm is in the way, but so here's the QL, but the QL kind of stops at the top of the iliac crest. It doesn't continue to thread through the ilium or the iliac crest to have an effect so much on the hip. But I often treat it, like I said, along with the psoas. So because they're very close together. And it's helpful to get your landmarks. So here's our patient. And I'm going to position them like this so that we can see the psoas here. So if we put everything on top, there's a lot of tissue, right? So here's our GB channel on the side body, and their arm is out of the way on your table. So we peel these layers back, and here's our psoas. So when they're on their side, you are going to find the top of the iliac crest right here, which is a very easy landmark no matter what sort of body constitution your patient has. So you're going to find the top of the iliac crest, and you're going to find the bottom of the rib cage. That is also a very easy landmark to find. So you're going to kind of reach around here. You might feel the 11th rib. You might feel the 10th. Just wrap your hands around the bottom of the rib cage. And this space between the top of the ilium and the bottom of whatever rib you're able to palpate here, the 11th rib or 10th, it varies tremendously from person to person. Some people have, like this model here, a lot of space. Other people have maybe like a 1/4 of an inch or a 1/2 an inch, and that's another sign. Like maybe the psoas is contracted, you know, maybe a lot of muscles are contracted. Maybe they have osteoarthritis and they're shrinking a little bit, you know, but most people have some space, even if it's just enough clearance for your thumb, right? But you'll find it's fascinating how that varies from person to person. So you can feel it on yourself, you know, the bottom of the rib cage. And if you want to lean, you can kind of start over in the stomach channel, spleen, palpate over, and then the top of the ilium. Ooh, it's tender there. So you're going to go, when you needle this, side laying, you're going to go straight. Let me see if I can get a little pin. You're going to go, add pin. Here we go. Oh, I can't really spin the pin. So this is the wrong angle. Let me see. Oh, that's the right angle. Psoas. You're going to go perpendicular to the side body, straight down. And what you'll do you can go kind of right on the midline. Don't go any further forward than that, you know, that midline of the side body. But what I often do is I sort of palpate off, well, there's a lot of tissue on top, so you're likely to feel, you'll feel the lats a little bit, but you can feel kind of the paraspinals. So right here, like iliocostalis and longissimus thoracis, like the UB line, right? So just kind of palpate and hug your fingers around to the lateral edge of the outer UB line around here-ish. And I orient myself there. So I'm kind of like feeling around, and then just go right anterior to that. Just a little bit off the paraspinals, you're more likely to hit the QL, which is right behind the psoas, right? And you can even take that needle and angle it forward anteriorly But don't go more than about 30 degrees. And when you go straight in, this is a pretty safe area. We can add some organs. Let's see. I mean, you know, the intestines are out of the way over here. They're all the way up here, the colon. But again, see how you want to stay in the midline, and you'll get it. You really don't want to start creeping up to the abdominals. You really want to stay right at that center point and go straight down. And you're looking for, and yeah, you've got to use a big long needle. You've got to use like a 3-incher and go slowly. And the patients will often they'll report a deep ache, and it will likely refer to the groin. And you might feel some resistance and some tension, because if you're needling into a tight psoas, that's what you're going to encounter. But just go slowly, and you know, oftentimes the patient feels nothing until they do, right? And then it's like a very, it shouldn't feel sharp. And that is like with every needle you put anywhere. You don't want it to feel like you're poking there's a needle in your skin, or you don't want it to feel like you're stabbing somebody's, organs or blood vessels. I mean, those acute kind of sharp pain fibers are not the ones we're aiming for in a muscle. Those C fibers are the dull, achy, heavy fibers. You want it to feel, I tell my patients all the time, I want it to feel bigger than the tip of the needle. You want to feel like a dull, achy, radiating pain. So if it's sharp or too strong, just back it off and change your angle. But yeah, you want that deep ache. And I hook this up to e-stim all the time. People have a lot of times too, if you have a really tight contracted psoas, think of how, it's so close to the intestines, right? It has a lot of digestive implications too. Like you could have, like somebody, when you release their psoas, they might really need to get up and go to the bathroom. They might have just a lot of chi and blood flowing through there. Yes, digesting life, exactly. Yeah, yep, very true. Yeah, that is so much what we do, right? We bring something in and we make sense of it. We process it, and then we gotta let it go. And we hold on to what we need, and we should let go of what we don't. And that is the energetic dance we do with our food, with everything. Yes, the Tao. All right, so that's essentially how you needle the psoas. And I think, does anyone have any questions about that? There's no substitute for real life, but it's pretty safe there. And if you look up how to needle it from behind in the UB channel and how to angle it, and that's kind of complicated. I think this is much simpler and in many cases more effective. Okay, so we have our flexors, and then, oh yeah, okay, I'm going to take the pins away. Okay, look at these glutes. Oh my goodness. Okay, so here we've got maximus, right? It's a very strong hip extender, but it also, it's big. The gluteus maximus has a tremendous job to do in the way of like keeping the pelvis stable and allowing us to stand upright and be strong. So it partially assists with abduction, like I said, in these fibers out here, but it's mostly an extender. And then this is that aponeurotic line I was talking about. So you can palpate around here, and then just in front of that line, right about where this little blue mark is, roughly, maybe a little further down in this area, you can get gluteus medius. So that's underneath glute max. And then even underneath that is the piriformis. And then even underneath that, underneath the medius is minimus. So that's at that tiny little chunk of muscle. And then you have all these smaller structures that, you know, we can get to too. But the gemellus, and I'm not going to focus too much on quadratus femoris. That's a good one to needle too. I mean, you can get that. UB36 is a really good point to reach that. But I don't want to overwhelm you with a bunch of anatomy and muscles. This is kind of a hard one to reach too. But what did I want to say about? All right. Well, here are the glutes. Very, very deep. Like I said, not a lot of vital organs in the way. So have at it. And then the SI joint right here, this like really yummy area with here. Let's put some connective tissue on here. Oh my gosh. The sacrotuberous ligament. So you can palpate this. You can kind of orient yourself to the PSIS where you put your, like right around here, where you put your thumbs when you do that stork test. But, you know, your lateral, UB27 is probably my favorite. 25, 26, 27. And then you can continue down to 30, curving around. But 25, 26, 27 really are like in this zone here, where you're just kind of aiming for this joint line, and you get a really deep ache. It's very satisfying, and patients can sometimes feel it refer all the way to the abdomen. It's pretty powerful. Let's see. So yeah, in the frontal, the anterior and posterior planes, you want those muscles to be balanced. Oftentimes, rectus femoris is going to be super strong, and it's not going to, I mean, gluteus maximus, it does not take much to strengthen that muscle. I mean, this little trick, I tell my patients all the time, when you're brushing your teeth, just do like, I don't know if you can see my leg, just do leg lifts, back, straight back. You know, when I'm brushing my teeth, I've got one of those toothbrushes, got to wait 30 seconds, you know, just straight back. And if you, for those of you who want to stand up with me, you can feel your glutes by doing that. And if, here, let's go over here. Okay. So if you point your toe and you externally rotate your hip and then go straight back, woo, now you're going to feel medius. And the thing about those little standing leg lifts, they're really easy to do, and most people can, even if they have knee problems and hip problems. You're going to feel the burn actually a lot in your standing leg. And maybe we'll talk more about that when it comes to the knee, because I often suggest that when people have knee problems. But you want, I mean, for the love of your lower back and your knees, you really need your glutes to be strong in order to bridge that gap. And the flexors and extensors in the anterior and posterior plane, they're gonna stabilize the pelvic girdle so that you're not like, if one group is stronger than the other, it's gonna pull the pelvis forward, right, or backward. So the adductors, a lot of the glutes, as you can see, because they're in here, and cross over to the side are also adductors, right? So out to the side, and the TFL is over here. Here's our IT band. So, you know, all of these adductors back here and in the side, adduction is super important because it's going to prevent the ilium up here from elevating and rising. So we want all of these structures that pull it down and keep it anchored in the superior and inferior plane, right? You want those strong so we can anchor it that way. So we can tip our pelvis forward and backwards, or it can shimmy side to side. So the adductors are hugely important in anchoring it straight down. So we've got the glutes again, as far as adduction. Medius is a really, really big one. Minimus is another really big one. So underneath there. And the TFL, of course, which I took away, is here. And then the piriformis, again, just to refresh your memory in case you forgot, it's only an adductor if the hip is flexed to 90 degrees. Otherwise, it's an external rotator. So helps bring the hip, the leg behind you. And then, okay, so let's shimmy around to our adductors. So adduction is important in stabilizing the hip and preventing it from, you know, elevating or falling. And so here is from the front where what I talked about, the iliacus and the psoas, right? So you can, the sartorius is a little bit in the way, but that's not a huge problem behind that. So if we find stomach 31, right, at rectus femoris, and then we kind of go up, or we find gallbladder 27 and go straight down, you have to get past the sartorius, but you can reach the psoas attachments here, but they're deep. And again, this is such a yin area, sensitive yin area. So if you treat it through more of the Shaoyang side body, you're gonna get more belly, like more of the muscle belly of the psoas. Iliacus is harder. So let's actually isolate iliacus, and you can kind of see what I mean by, like, if, so here's the ASIS and here's GB27, right? You got to kind of aim your needle laterally from the medial side, right? You got to curve it around the corner. So it's tricky. So it might be a little easier to needle the iliacus attachment down there, but the kind of the belly of the muscle, you're going to probably be able to reach better from GB27. And you just have to be careful of, you know, of course, the van line, right? Our arteries and veins and nerves. So in this area, the femoral artery and vein, the way I remember it is VAN, right? The vein, the artery, and the nerve from medial to lateral. So you just have to be careful because here's iliacus, you're off to the side, but look at where the psoas attachment is. I mean, you're right there. So you got to be so careful, and you really want to like palpate for the pulse here. And then you want to go lateral to that, but just know that the nerve is like, yeah, you may hit that if you try to go in from the front. So, it's safer. And then you have more clearance actually up above if you want to go in from GB27. Let's take some muscles away, right? So you know, there's some nerves here, but you have some room to shimmy your needle through there. So just go slow. And again, if you hit a little nerve, the anterior cutaneous branch of the ilio, blah, 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 I don't even know that nerve, but there's so many. But yeah, you know what that feels like. Just back it off, change your angle, and you'll be okay. Oh my gosh, look at this. Look at this vein and artery spaghetti. It's crazy. Oh my goodness. All right. What else? Oh yeah, so some of the adductors down below. So here's pectineus. That is our leg crossing muscle, a big leg crossing muscle. So you can reach that. Again, you're gonna run into a lot of anatomy there. So you got to be really like venous arterial neuroanatomy. So you got to be careful. But I don't think the pectineus is like a huge priority to needle, but we're going to look at how to tease these out as best we can. And we may kick off class with that next week. But pectineus, sartorius, we talked about that. Let's get that out of the way. So underneath the sartorius, if here's right where the cursor is, if that's stomach 31, you can kind of shimmy laterally. And then just straight down from there is adductor longus. And remember brevis, that tiny little one behind. So if we fade all these, there it is. So it's super, super deep. And if we isolate it, that attaches to the pubic bone, and it's hard to get to. But I've given you all the motor points in your notes to orient yourself. So there it is. That's why that gray dot is, well, no, the motor point really kind of is in this tiny little area. The adductor longus is a little easier to reach. So that also kind of sneaks behind rectus femoris though. So it's easier to get in the medial area. So you don't have to go through rectus fem because it's a big muscle. And then we've got adductor magnus. The thing about, let's isolate adductor magnus. Adductor magnus attaches to the ischial tuberosity. See back here? So this can literally be like a pain in the butt, but like right in, like on the sit bone. There's a couple of other muscles in the hamstrings that are there, but like right kind of in the zone of UB36. But that muscle, that little adductor, you might more commonly strain it at this attachment here from behind. So here's the front. And then last but not least, here we have gracilis. So gracilis is very, very in. I don't want to, I think that was all the muscles I had on your list just to become aware of. But adductor magnus, I think, is the one where I had that little gray dot because you also have to kind of sneak behind other muscles to reach it. So if we fade the others, you're going to needle it like right around here where my cursor is. So you're going to have a bunch of other stuff on top. Okay. Was that fun? 3D.
Yeah.
3D anatomy. Yeah, right? It's nice to see. Okay. Computer's like heating up again. Okay. We've only got 5 minutes left, but let's just let's start and we'll pick up where we leave off. But I just want to kind of give you an intro We're going to start with just a simple hip flexor strain. You're going to see that a lot, super common. But all this stuff we just talked about and all these muscles I just talked about, there's a point to that. So hip flexor strain, right? Kicking, running, even walking, gymnastics, climbing. I mean, oh my gosh, you name it. There's so many things that recruit the hip flexors. So repetitive strain by abrupt and forceful elongation of the hip flexor. So kicking, really. I have a lot of soccer injuries with hip flex, and these can go on for years. So pain in the anterior thigh anywhere, really. I mean, look at this huge area, right? Lateral to anterior, medial, like it might refer to the groin or just below. It could be mild and pulling, and it could be something where like, okay, it might hurt when you're running, but you can keep running, and then it gets progressively tight and obnoxious as time goes on or even as the day goes on. And you really don't want your hip flexors to start to become weak and inhibited, because if one goes down, all these others have to jump in and compensate. And as you know and saw, they do all these other things too. So, you know, if one major member of this important army says, well, I'm out, all the other ones have to step in, but it might not really be their primary job to do the action. So they're going to start to get fatigued, and it leads to this cascade of compensation and other muscles turning off, right? So there are 5 muscles that you want to consider. And when we meet next week, we'll run through how to isolate them and test them. But the iliopsoas, which is that one, boop, meaning the attachment, right? So that's a huge, you might feel pain in the groin, but we might treat the side body to get that one, right? And then rectus fem, boop, that one, right in the front where stomach 31, 32, 33-ish is. And this is in order of most commonly affected, okay? The TFL, whoop, is there. I can't help but make that noise when the numbers jump. So that's out there. The sartorius, whoop, is there. And then pectineus is last. But it is one to consider because it's like a leg crossing muscle. So when someone complains of pain in the groin or the anterior hip, you're going to want to manual muscle test each of those and sort of tease it out. And, you know, where they're pointing tells you a lot, but you're going to learn how to test each of those muscles so that you can effectively treat the muscle that might be the culprit. And if you forget it all and you don't know, you know, and you can reach them, hey, it's okay to say hello to all of them. You got five needles isn't too many. So so I think at 4:28 it's a little late to jump into that now, but that's where we'll start next time, the iliopsoas. And I will let you guys all go. And thank you so much for your attention today. And I love this class, and I love, even though I know I'm not talking to myself, I'm talking to all of you, and I feel it. So thank you for participating, and have a wonderful weekend.
Thank you.
too.
You too. Yeah.
Thank you, Jennifer.
Thanks,
Thank you.
everybody.
Thank you.
Bye.
Bye, Jennifer.
Bye.
Hey, Jen.
Hi.
Hey, how's it going?
It's good. How are you? Oh my gosh, look at you.
I was curious if tomorrow is okay. I sent you a message. It was a little late. I just sent it. And for the makeup.
Yeah, that's totally fine.
Okay.
Yeah, I will. You're gonna get a link to your email, probably in 2 different ways. And that's the one you're going to want to access.
Okay. And the other thing I was curious about was what days you're doing externships next fall,
So
if you have any.
yeah, if you're interested, let me know because I have kind of a list. And I'm somewhat flexible because I know that whoever's next on the list, I'll just kind of like work through what works with your schedule if that time is available. But basically, Monday through Thursday, I'm here. So and then Fridays I'm teaching, and next semester I'm going to be doing 2 classes. So I won't be. I try not to see patients on Fridays. So Monday through Thursday.
Okay, great.
Yeah, do you want me to put you on the
Yes,
list for that? Okay, cool.
Yeah, and Thursday would be preferred.
Okay. All right. Awesome. Well, I will email you the link. Have fun doing whatever you're doing out there.
Thanks so much.
And I'll keep, if you don't mind, send me a quick email when you have turned your test in, and then I will grade it, give you feedback, and give it back to you, and it'll be all good.
Awesome.
Yeah. Okay.
Excellent.
Have a good
Thanks so
weekend.
much. You too. Be well.
You too. Bye.